Okay. Hello, everyone. I'm Kelly, and I'll be your host for today's webinar, Do's and Don'ts of Ultrasound Ergonomics. Our presenter today, Ms. Molly Siemens, earned her Bachelor of Science in Diagnostic Medical Imaging from Fort Hays State University in Kansas. Molly has been a practicing sonographer for 14 years, scanning mostly in the challenging fields of maternal fetal medicine and fetal echo. Since she complains of pain much less than I do, I definitely think we should listen to her presentation, Do's and Don'ts of Ultrasound Ergonomics.
Thank you, Kelly, and welcome everyone. I know there's some that are still joining us, but we decided to go ahead and get started because we do have a lot of information today. Due to the amount of information and the number of people jumping on today's webinar, we do have all cameras and microphones disabled for the time being. However, if you think of a question or a comment during the course of the presentation, please feel free to reach out to us using the Q&A button located in the webinar toolbar, either at the top or the bottom of your screen. Following the completion of our material, I will address each of your questions in the order in which they come in. Also, following today's webinar, you will receive an email with instructions on how to obtain your CMEs, as well as an evaluation of today's presentation. We would love to hear back from you, what you liked, what you didn't like, and if you have any recommendations for future presentations. So again, thank you all for joining us today. The objectives for today's presentation are to define work-related musculoskeletal disorders, describe common symptoms of these disorders experienced by sonographers, outline strategies to prevent these types of disorders in the scan room, and illustrate some preventative and practical exercises for sonographers. This quote comes to us from Lily, who's been a sonographer for 20 years. When collecting material for this webinar, we reached out to sonographers to gain insight on those who are scanning in pain. We received a wide range in responses from sonographers who are celebrating their first anniversary in the field to those who would be considered long haulers, those that have 20 plus years of scanning experience. While a lot of us have or are currently scanning in pain, knowing that there are sonographers out there with this much experience that are still picking up a transducer, it gives me hope for my future, and I hope it does for you as well. Well, a majority of this presentation is going to be on how to protect ourselves and hopefully prevent injury. I would like to briefly define WRMSDs as they apply to sonography. So what are WRMSDs? These are work-related musculoskeletal disorders. They're activities in the workplace that cause or exacerbate an injury. This injury may affect muscles, ligaments, tendons, joints, or nerves, and is caused by any forceful or repetitive awkward movements. Surveys among sonographers in the United States indicated that the number of us scanning in pain jumped from around 80% in the mid-90s to around 90% in 2008. This large number of injured sonographers is where ergonomics comes into play. The generic definition for ergonomics describes it as the observation of how one interacts with their workspace, as well as the study of how one's workspace can be designed in order to make it more safe and efficient. In ultrasound, this translates to how we set up the machine, how the patient is positioned, and how we position our bodies while scanning. Common symptoms of WRMSDs have been reported include pain or achiness in a joint or muscle group, stiffness, tingling, burning, or a pins and needles sensation, numbness, and even visible symptoms of swelling. These symptoms can vary in their location as well as how intense they are experienced. While you may experience a subtle ache in a joint after a full day of scanning, a coworker may experience debilitating pain after the first patient or two. In addition to the variety of symptoms that occur, it is also important to note that while some may experience an intermittent pain that doesn't occur daily, these types of injuries can progress from a minor acute injury to one that is chronic and potentially incapacitating if corrective measures are not taken. Sonographer WRMSDs can be caused by multiple factors. These factors may be things that we can control, such as workplace habits, or things outside of our control. Controllable workplace habits include body position, or the posture we hold ourselves in while scanning, and pressure, or the amount of force or grip we apply to the transducer, or how hard we press into patients in order to get diagnostic quality images. We'll discuss some ways to mitigate these factors in order to protect ourselves in the next section. Factors that are out of our control include how our workload is managed, the performance of repetitious movements daily, as well as various miscellaneous causes. The expectations of our daily schedule is probably the most common risk factor for WRMSD that is out of our control. This may be due to an increased number of patients needing to be seen, staffing shortages due to illness, retirement, or resignation, and studies being scheduled in inappropriate timeframes. When these scenarios occur, it can lead to decreased recovery time between patients, sonographers not taking the time to adequately optimize their workstation prior to starting the next patient, and sonographers not getting or taking scheduled breaks. Personal beliefs can also be a detrimental factor contributing to WRMSDs caused by our schedule. If you go all out to get that quote perfect image, or continually push yourself to scan despite the pain in order to not let down your team. Repetitive movements may also initiate WRMSDs due to the same muscle groups being continuously activated. This also allows for less time for our muscles to recover, which can lead to muscle fatigue, inflammation, and eventually degeneration of the muscles themselves due to a buildup of waste material. While any sonographer is at risk for repetitive movement injury, sonographers who are highly specialized are probably at the highest risk, such as those that perform adult echocardiograms and MFM sonographers. Miscellaneous causes that can lead to the development of WRMSDs are factors that don't really fall into these other categories and may seem, well, kind of odd at first glance. Age is one such cause. Some studies have demonstrated that our risk for developing a WRMSD increases as we get older, specifically after we reach 50 years of age. This may be due to a natural decrease in peak muscle strength as we get older, as well as age-related muscle and bone degeneration. Certain anatomic variants can also predispose a person to WRMSDs. Hypermobility is one such common anatomic variant that puts a person at increased risk. This occurs when a person has increased laxity in their ligaments, which allows for wider ranges of movement. And lastly, short stature, defined as shorter than the national average, may make one more prone to injury as well. As I stated before, when preparing for this webinar, we asked members of the Facebook group Sonographers Do It in the Dark to help us with a short survey related to pain while scanning. These are the results from that survey. The first question we asked was the number of years each respondent has been scanning. The average sonographer that responded has been working in the field for around 7 to 8 years. The shortest career reported was 5 months, while the longest was 38 years. Another survey question was in regard to the area or areas of ultrasound each respondent practices. Most responses to this question were general small parts at around 29% of the 106 respondents that we got, with OB being second at 17%, and the combination of general vascular, the third most popular at 13%. Other reported areas included vascular, echo, MFM, breast, or a combination of multiple areas. In addition to years of service and the primary area of ultrasound that they practice in, we also asked how many patients they scan per shift, what a typical shift looks like, if they experience pain during or after the workday, where their pain is located at, and what remedies they use to help with this pain. The average number of patients scanned per shift was about 10. We received one response of 30 patients per shift and a few responses of 5 patients per shift. The 30 patient per shift response came from an OB sonographer, while the sonographer scanning 5 patients per shift reported working shorter shifts or were in more specialized areas such as MFM. The most common, quote, typical shift worked was 5 8-hour days per week, But again, responses were quite varied, with some reporting 3 12-hour days, 4 9-hour days, plus 1 half day per week. And even one respondent that responded that they work 7 long shifts in a row, but then get 7 days off in a row. 71 of the sonographers reported in, or about 67%, stated that they either scan in pain or experience pain at the end of the shift. This was a little lower than I anticipated, especially compared to the SDMS white pages on WRMSDs. However, our survey was considerably smaller, which was definitely a limiting factor. Of the 67% that report pain, most respondents reported scanning mainly general and OB exams, with the average number of years in the field at 8 and the average number of patients per shift at 10. These numbers were nearly identical to the overall results of the survey. The most commonly reported single area of pain was the shoulder. However, most respondents reporting pain reported that they had it in multiple areas, with the most common combination being the neck and the back. When I looked at all of this data, all of these numbers that we collected, the one thing that surprised me about the pattern was that there really was no pattern. Some respondents, there was a pretty obviously clear red flag, specifically two that reported starting their career a year ago or less and are already scanning a pain, but they also reported scanning 23 to 30 patients per shift respectively. So that's a lot of patients in one day. Other respondents reported pain after 5 to 8 patients per 10-hour shift, while some that scanned 12 patients or more in an 8-hour shift reported no pain at all. While our study did demonstrate that general and OB sonographers tend to scan in pain more often, contrary to what we saw in the literature, there really was no common denominator for the shift worked or patients per shift or even years of experience. So really what this tells me is that we're all at risk for injury if we don't take the proper steps to protect ourselves. The first step in protecting ourselves is knowing what can cause a WRMSD while scanning. We've already mentioned that some contributing factors include our posture while scanning, as well as the amount of pressure or force that we use. Over the next several slides, I'd like to present some tips on what to do and what not to do in order to help oppose those factors. These slides have been broken down into the most commonly reported areas of pain: the hands and wrist, the shoulder, the neck, and the back. Other areas of pain that were reported in our survey that were not described in the literature included the elbow, hips, and even migraine headaches. I'm hopeful that the tips provided will be helpful for those trouble areas as well. Some of the injuries that occur to the hand and wrist are caused by how we hold or grip the transducer. When gripping the transducer, we want to make sure that we don't use a pencil grip. That is, holding the transducer like we would a pencil, kind of pinched between the thumb and index fingers. Holding the transducer like this forces us to use some of the tiniest muscles in our body while using up to 5 times more muscle and tendon force. It also makes it way easier to potentially accidentally drop the probe, especially if you're like me and use more gel than is probably necessary. So again, we want to avoid using a pencil grip. Instead of a pencil grip, we want to use a palmar grip. Holding the probe in the palm of your hand with the fingers lightly wrapped around it instead of just between the fingertips helps distribute the weight of the transducer more evenly and reduces the amount of tendon muscle force needed. While using your palmar grip, another thing that we want to avoid is squeezing the transducer to the point that our fingertips and knuckles look like the image demonstrated. Our fingertips should never look like they're turning white from the amount of force that we are using on the transducer. Some may find yourself squeezing like this when scanning patients of an increased body habitus or when performing lower extremity venous exams and trying to image the structures in the groin. If you're like me, there may be times that you're gripping the transducer like this just to avoid letting it slip out of your hand due to the amount of gel or the amount of pressure that you're using. But a grip like this should definitely be avoided as much as possible. When we squeeze a transducer this hard, it puts increased tension on the tendons passing through our wrist, leading to inflammation of those tendons or the tendon sheath, causing tendonitis or tenosynovitis. This type of grip can also cause trigger finger, when the inflammation causes the tendon to become edematous and traps the finger tendon in a locked position. De Quervain syndrome is a form of tendonitis located within the thumb that can also be caused by excessive grip of the transducer, specifically when the transducer casing is pressed against the base of the thumb. Instead of squeezing the daylights out of the probe, I myself am guilty, we want to try the following. Try to avoid or at least minimize the activities that would cause you to grip the probe with that much force. I realize that this is easier said than done, especially depending on our schedule and the number of teammates that are available to help share those certain types of exams. Too forceful of a grip is something that we may do subconsciously as well. So if possible, try to train yourself to pay attention to your hand periodically while scanning to make sure that you aren't gripping the probe too tightly. Your hand should look like the image demonstrated, a light grip with as little pressure as possible. You should be able to see in this picture how relaxed the index and the thumb are. If the excessive squeezing is because of patient body habitus, try optimizing your machine settings before getting too far into the protocol, altering the frequency or turning off or on harmonics, and then using an alternative window. Have the patient adjust their position in order to get an easier or shallower window to the anatomy that we are looking at. Lastly, wearing appropriately sized textured gloves can also avoid gripping the transducer too tightly in order to avoid dropping it. These images demonstrate something else we want to avoid, which is extreme flexion of the wrist. By scanning with our wrist in this position for extended periods of time, we run the risk of placing increased pressure on the medial nerve in the wrist, which is what causes carpal tunnel syndrome to occur. Not demonstrated, but something similar to extreme wrist flexion is extreme elbow flexion, which can cause cubital tunnel syndrome. Though this can also be caused when there's excessive pressure placed against the ulnar nerve, such as when we rest our elbow on or against an exam table. Twisting and flexing our wrist is another one of those subconsciously unavoidable things that we all do. I perform a lot of OB exams, and I'm always finding myself doing this when trying to get the aortic or ductal arch. I feel like if I just turn just a little bit farther, I can get around that spine. But we really want to try and avoid this much posture as much as possible by keeping our hand, wrist, and forearm in a neutral position. Just as we mentioned with transducer grip, we really want to periodically take a look at how we're scanning to make sure that we aren't scanning like this for too long. If you find that this is unavoidable, again, try changing the patient's position in order to get them better aligned with your arm. We also want to make sure that we're moving our forearm when moving to different organs or places along the vascular system, rather than trying to turn our wrist to get to those organs. And lastly, when turning from the transverse plane to the sagittal plane or vice versa, turn the probe in your hand rather than turning it in your wrist. Moving from the hand, wrist to the shoulder, the biggest concern with the shoulder, or the most common cause of injury, irritation, is arm abduction as demonstrated. This occurs when the arm is raised away from the side of the body more than 45 degrees for an extended period of time. Overabducting the arm can lead to compression of the nerves of the brachial plexus, or it can lead to restriction of the blood flow to the muscles and tendons related to the shoulder. These muscles and tendons are already less perfused than other areas of the body, so when further compromise occurs, such as in this scenario, there's a further risk of rotator cuff injury due to there being less oxygen brought in and an impaired ability to get rid of wastes. Overabduction of the arm occurs when the chair or bed height isn't appropriate set most commonly. Obviously, the first thing that we want to do then is adjust the height of the chair that we're sitting on or the bed that the patient is on, ideally to a point where the arm is abducted less than 30 degrees away from our body or as close to our side as possible. Depending on the type of exam we are performing or a patient's body habitus, standing a scan may be a better option to reduce the angle of our arm. Last-ditch efforts, and if available, try standing on a low but widely based step stool in order to get the height that you need in order to reduce the height of your arm. Your scanning arm is not the only shoulder that can become injured, though. We also want to make sure that our machine is adjusted appropriately, too. The console should be at a height that doesn't make us raise our non-scanning arm too high. The biggest obstacle to this is when performing venous reflex studies, and one has to reach up to annotate or freeze an image while scanning the patient's lower legs. One recommendation that I saw in the literature stated to have the patient stand on the table when performing this type of exam to avoid overreach. I don't know about you, but I don't think I'd feel comfortable asking a patient to stand on a table. If possible, it might be a better idea to have some sort of a tiered step stool with a handle that the patient can hold on to rather than asking them to stand directly on the table. While inappropriate bed or chair heights can attribute to overabduction of the arm, an inappropriate patient position can also lead to overabduction of the arm. One of the first things that we should do after adjusting our chair or bed height is to have the patient move as close to us as possible. As you can see in this demonstration, our patient is to the right of the center of the bed, but still adequately supported. Our sonographer's arm is also in a neutral position, definitely less than 45 degrees. Of course, this is something that is much easier to undertake in outpatient settings when our patient is quite mobile. For inpatient settings, especially those in which our patient is completely immobile, adjusting position is difficult, if not impossible. So for these patients, we do have a few options. One would be to scan what you can from one side of the patient's bed, and then moving the entire machine to the opposite side to obtain the rest of the necessary images. This was something, again, that was recommended in the literature, but it can be quite time consuming to do that and may not be technically feasible depending on the size and the layout of the patient's room. The other option then would be to employ help. Have a student, a fellow sonographer, or even a member of the nursing staff assist you by running the machine while you scan from the opposite side of the bed. Our neck is, like we said, another area susceptible to injury. The intervertebral spaces in our neck are more flexible than other portions of the spine, but if we hold our neck in a fixed or awkward position for too long, it can build up tension in the muscles of our neck, which can lead to fatigue. Combining this fixed position with the elevation of our shoulder, especially if we're over-abducting our arm, we can further create neuromuscular tension problems. These types of positions can also be further exacerbated by age-related spinal degeneration. And one such abnormal posture is demonstrated here, keeping our head tilted down in order to see the monitor. Obviously, the easiest solution is to make sure that the monitor is adjusted to an appropriate height for you. The monitor should be kept at eye level at a position where your chin is neither too extended or too flexed. So we're going to do that by keeping the neck vertebrae at a nice neutral position. Another abnormal posture is demonstrated here, turning our head in order to be able to see the screen at the same time as the patient. Obviously, the best remedy for that is to make sure that, again, the monitor is at an appropriate height for your eyes and having the screen turn so that it is facing you. This is probably something that we find most difficult in performing OB or MFM scans just due to patient expectations. Patients often expect to be able to view the entire scan from start to finish. Fortunately, most OB and MFM offices have separate monitors that allow the patients to view the entire exam. However, there are some of you that work in facilities where you perform a variety of things, which may include OB. So having that extra screen might not be an option. Our goal then is to minimize the amount of time spent with our next training or sharing the screen, which means keeping that screen facing us for as much of the exam as possible. Now, this may cause a frustrated response from the patient. However, we've found that if we are upfront and honest from the beginning with the patient by explaining what we're doing, the images that we need to obtain, how long the exam should last, and that they will be able to see the screen at some point, patients are much more at ease by this and not getting to see the screen the entire time. Moving from the neck down into the back, the image demonstrated here looks pretty appropriate, right? The chair and the table are adjusted to the right height for the shoulder, the patient is close to the sonographer, and the machine console is adjusted nicely as well. So what is the issue? Well, unfortunately, it's the chair itself. Sitting, especially for long periods of time, and in unconventional chairs, such as the stool demonstrated, can distort the shape of the spine by putting pressure on the intervertebral discs. This increased pressure then increases the tension on the muscles, ligaments, and other soft tissues related to the spine. Unconventional chairs, like stools or standard office chairs, can also reduce pelvic mobility by locking those muscles into place. So if you are accustomed to sitting while scanning and you start noticing hip or back pain, try standing to scan. Standing can take the pressure off those intervertebral discs while allowing for more mobility in the muscles of our pelvis and hips. Standing is especially helpful for exams that could potentially require a lot of twisting of the body, such as lower extremity venous exams, when one has to turn to augment the leg. When standing, we want to make sure, however, that we are standing with both feet in front of us and that the patient is still as close to us as possible. Personally, I am the worst at standing just because I find myself shifting from one foot to the other or leaning into the table while scanning. So if you're like me, it may be best really to vary between sitting and standing from patient to patient, just in order to protect yourself as much as possible. Finally, for our last quote, we don't want to scan like this, with our machine console adjusted so low that we have to stand with our back bent forward like this for extended periods of time. Instead, we want to make sure that our machine console is, again, adjusted to an appropriate height. The left image demonstrates this for standing to scan, and the right side is sitting to scan. Both images, the sonographer's back is straight and neither arm is abducted. So here is a checklist that I use prior to every patient I perform. And it probably seems a little repetitive to go through all of these steps for every patient all throughout the day, but every patient scenario is different. And using these little steps can be the start of a healthy scanning habits. As we've mentioned multiple times, starting with the appropriate height of the bed of the chair, adjusting to where you need them to be. If possible, using a bed that automatically adjusts with the remote is best, not only for you, but for the patient as well. Again, making sure the patient is as close to you as possible and adjusting the console. So it's easy to reach. You're not reaching clear over to the side to type things in. It's at a comfortable height and that your body isn't twisting towards the patient or towards the console. Again, adjusting the screen to eye level. That's comfortable to see without twisting our neck. And then other things like using an adequately sized room. This may be, again, harder depending on where you're at, but we really want to make sure that we have ample space for us, the machine, and the patient. All of these things help keep you and the patient safe. Adequate lighting is also something to keep in mind, just to avoid excessive strain on our eyes. Some studies recommended taking many breaks throughout the course of the exam to focus our eyes on farther objects away that are farther away, especially for performing longer studies, just to, again, help avoid eye strain. Blue light blocking glasses are something else that can be helpful as well. Adequate temperature is probably something that sounds a little silly, but if you're too hot while scanning, it can make you uncomfortable, and then we start fidgeting and moving, which can lead to those awkward positions and twisting. In addition to these steps, some things to try is trying to vary exam types, if possible, especially when working in larger facilities and not by ourselves. varying how we scan, again, sitting versus standing. Keeping our scanning area separate from our report workstation, or at least making a point of getting up between patients, moving around, either to call them back from the waiting room or just walking up and down the hallway once to allow our muscles to recover in between patients. Using different probes, especially in OB, I feel like I tend to use the 3D probe a lot routinely just because of the ease of using that technology. But try alternating, using a traditional curvilinear probe for an exam or two, and then going back to the 3D probe. Again, this just kind of helps release a little bit of the tension that we have to use when using the 3D probe. Again, these are all steps that we can take to just help our muscles recover in between patients. While these tips are a great start in preventing injury, I really wanted to know the tips and the secrets of those long haulers, the ones who have been scanning for 20 plus years and are still going strong. So we added some additional questions to our survey, specifically those sonographers that have been scanning 15 or more years. This quote was one of the responses that we received and came to us from Cindy, who has been a sonographer for 40 years. The rest of the tips that we received from experienced sonographers, we condensed down into this list. Becoming ambidextrous, as strange as this sounds, being able to scan with both hands can allow your dominant hand a little bit of time to relax and not become overly fatigued. This does take practice, however, and it has been suggested that the easiest exam to train your non-dominant hand is carotid studies, so something that you might want to try out. Getting help, advocate for excellent teamwork. Have a fellow sonographer or a student assist when adjusting a patient's pannus for OB scans. Have another staff member assist with running the machine when performing mobile studies. Assistance isn't a detriment. It shows that you're caring for your patients while also protecting yourself and your coworkers. Don't fight with the linens. If you're performing an OB or pelvic exam, take the time to make sure that the patient's slacks are pulled down low on their hips before tucking the towel down. Or if performing an abdominal study, have them change into a gown rather than trying to tuck the towel up under their shirt. Not only will these steps keep gel from getting on the patient's clothes, but it also means you won't be using additional pressure or extreme wrist flexion just trying to get around the linens. Using contrast, this was recommended for cardiac sonographers when scanning patients of an increased body habitus. Admittedly, I do not perform adult echo, so I cannot comment on the futility of using contrast in these scenarios. So if any of you do perform echo, please feel free to chime in the comments. Using physics, using organ interfaces when scanning abdominal exams, or as highlighted by the quote on our last slide, always be thinking about how you can decrease the distance between your transducer and the target that you're trying to image. We can also use post-processing tools. This may be something as simple as an auto-optimize feature or decreasing the gain to make fetal cardiac images have more contrast. But this can also mean taking cine clips of the area of interest, such as on a patient of an increased body habitus, and then going back from that cine and obtaining the stills and measurements off of those clips, or using 3D technology to gather a volume and then reconstructing the volume to get more specific details. All of these steps will decrease the amount of time we spend pushing our bodies just to get the necessary images, especially on, again, patients of increased body habitus. Our final 2 bullet points, though, kind of go hand in hand. Knowing when to stop and reporting any limitations. And knowing when to stop is huge. I used to think that I was doing my patients a disservice if I didn't spend, 40 minutes to an hour just trying to get textbook perfect images on morbidly obese patients. But friends, you cannot do that to yourself. If you've optimized the image as best as you can, you've tried different patient positions and alternative windows, and your image still looks like a cloud rolling through a snowstorm, take an image to document that anatomy was suboptimally visualized and in the exam. That's not something that you have to do just to take care of yourself. As mentioned previously in the presentation, another survey question that we asked was in regards to pain relieving strategies. We hope that you won't find yourself in a place where you need these strategies, but should it arise, these were the most common tips that were recommended. Using professional massage or getting a professional massage, whether it's traditional or deep tissue, kind of depending on your preferences. This can help work out those muscles that get overused the most. Remember, though, to drink plenty of water before and after. Massage guns or the personal massagers can be helpful to work problem areas when you can't get to a professional, as well as using hot compresses, heat patches, warm bath, or the microwavable neck buddies, something that just helps the muscles relax. Foam rollers, again, similar to massage guns to work the problem areas that we might have. Over-the-counter pain relievers, Advil, ibuprofen, Tylenol, Aleve, just making sure that we're using them per the manufacturer's guidelines and not taking too many. TENS unit, something else that can help stimulate those muscles to hopefully relax them. And then cooling ointments too can sometimes help with topical pain relief for tense muscles, whether it be BioFreeze, ice packs, or icy hots. Some essential oil brands even have their own type of cooling ointment as well. Muscle relaxers were something that were mentioned. And finally, stretches. Several responded to our survey stating that they perform yoga or lift weights just in order to strengthen and lengthen some of the muscles that we utilize daily. Some even listed specific stretches that they perform, which was awesome, such as arm circles, wrist rolls, or neck rolls. While we're all familiar with stretching before or after exercising, such as going for a jog, stretching and exercising before or after our workday or in between patients can also be a huge benefit in keeping our bodies healthy. A long, healthy career means taking care of ourselves. As we just mentioned, this begins with staying in shape. The healthier your body is, the less likely you're prone to injury. Invest in good shoes. There are a lot of opinions online as to what the best shoes are, from medical clogs to specific brands of running shoes. But no matter what option you choose, make sure that they are an appropriate fit for your arch and that they have a nice cushiony sole. Something else that we can do to take care of our bodies is to take vacations. While we compare our bodies to machines, we are definitely not machines. So take your PTO or your vacation days. Use that time to relax those overused muscles or just as a mental break from the stress of what we do. And finally, be a team. Help your fellow sonographers and trust that they will be there for you as well. This quote comes from Mindy, who's been a sonographer for 16 years. I really like what she said about doing something to clear your mind so that you can be 100% at work. And I feel like that is just something really good to keep in mind before and after the workday. For our last section, we have a collection of stretches and exercises provided by Becca Frede, a certified group and fitness instructor and bar instructor, and a technical assistant in our Central Texas region, who is currently pursuing her degree in nutritional sciences and public health with a minor in business of healthcare. Some of these exercises we're about to show you can easily be performed between patients, while others may be incorporated into a daily stretching or exercise routine from home. If you would like, please feel free to try them out as we go along. Our first stretch is a chest stretch, which opens up the chest muscles and help relieve pain in the upper back. Starting by kneeling on a soft surface with your legs hip width apart and the toes pressed in the top of your feet pressed against the floor, sit back on your heels, rounding the spine, bringing the chin to the chest, and tucking the hips under. Reach the arms forward to stretch out the back. Inhale as you squeeze your seat to rise onto the knees, pressing the hips forward, keeping the core engaged, and tuck the tailbone under, opening the chest and arching the upper back. Bring the gaze slightly upward, lifting your chin, and reach your arms out long in line with the shoulders or slightly above and gently pull the arms dorsally by squeezing the shoulders blades together. Exhale as you sit back onto your heels, repeating this movement as you move with your breath. Our next stretch is a head and neck stretch. This eases tension in the trapezius muscles, the head, neck, and upper spine. Sitting in a chair or comfortably on the floor, close your eyes and breathe deeply. Gently tilt your head to one side and let it drop towards your shoulder. Do not raise your other shoulder and do not force your head down. Another option is to gently pull your shoulder down as you drop your head to the opposite side. We want to hold this for 3 to 6 seconds. And then gently roll your chin forward to relax it onto your chest before switching sides. You can repeat this 3 to 4 times. I realize I'm going through this a little fast. This will be available to you as part of your email, so don't worry, you will be able to go back and view these shoulders in your stretches in your spare time as well. Our next stretch is a shoulder stretch. This helps ease tension in the shoulder. Stand with your feet hips width apart and bring your arm to your chest, reaching laterally. Your feet should be planted firmly into the floor with your gaze forward. Keep your back flat and hips slightly tucked under to ensure the core is engaged. Gently pull your slightly bent elbow or forearm toward your chest with your right hand as you exhale, keeping your shoulder blades together to create an opposing motion. Extend your hand as if you are reaching to feel an extra stretch, and you can circle the wrists left and right. Keep the shoulder blades pressed down and the neck relaxed, and hold this for 5 to 10 seconds before switching sides. Our next stretch is an abdomen and oblique stretch. This elongates the abdomen and keeps the chest and opens the chest and hip flexors. Kneel on your knee on a soft surface with the top of your foot on the same leg pressed into the ground. Keep your other knee on the ground and position the sole of your right foot against your inner thigh. Place your palm on the ground behind you, fingertips pointed away from your body. From this position, exhale as you extend the opposite hand overhead and press your hips upward to open the forward and up, squeezing from the seat and opening the chest towards the sky. Tilt the chin upwards to open the airway. Inhale to lower down. And repeat as many times as you would like, then switch sides. This is a quadricep and hip flexor stretch. This helps with leg cramps and increases the blood flow in the legs. So to do this, we want to stand and hold onto a sturdy object, such as the railing demonstrated, but you can use a chair or just even the wall. Bend your one knee and grab your foot with the hand on the same side, bringing your heel towards your buttocks. Squeeze your seat and push your hips forward slightly to feel a deeper stretch. Keeping your back straight, your tailbone rotated towards the floor, and your core tight, hold for up to 30 seconds. Try to get your knee in line with your standing leg or behind it, and keep a soft bend in your standing leg to protect those joints. And then repeat with the other side. The wrist and forearm stretch flexes and extends the wrist and forearm muscles. Sitting or standing up straight, you want to extend one arm out in front of you with the elbow straight and the hand flexed. Stretch the forearm muscles by placing the palm of the other hand across the front of the first hand and push toward the body. You want to hold that for 5 seconds and then switch to the other side. The shoulder pass-through is another shoulder stretch. We perform this with an exercise bar as demonstrated, but you can use an exercise band, a broomstick, or even a towel if you're performing this in your office. This stretch increases joint mobility and engages supporting muscles of the shoulders. So you want to start off standing with your feet shoulder width apart and your arms in front of your body. Hold a stick, such as demonstrated, or the towel or resistance band with an overhand grip. Your arms are going to be wider than shoulder length. Make sure that the stick or pipe or towel is parallel to the floor. Engage your core and slowly raise the towel or the stick or the resistance band above your head, keeping your arms straight. Go only as far as comfortable. Hold this pose for a few seconds and then return to the starting position. And you can repeat this up to 5 times. The chest opening stretch elongates the chest, expands the abdomen, and stretches the anterior shoulders. To do this, you want to stand with your feet hip width apart, parallel or slightly further. Ground yourself through all four corners of your feet and clasp your hands behind you. Inhale as you puff out the chest, rolling the shoulders down and back, straightening out the arms and arching the back. Keep the chin slightly lifted and exhale as you release, dropping the head, rounding the spine, and gazing the eyes towards the toes. Repeat, moving with your breath. The back stretch will help lengthen the spine and relieve lower back pain and tension. To do that, you want to kneel with the tops of your feet pressed into the floor, placing both palms on an exercise ball or flat on a wall. Keeping your hips over your knees, exhale as you tuck your chin and extend your arms to roll the ball forward until your upper body is parallel to the ground. Draw your shoulders away from your ears and arch your lower back to a comfortable position, holding for 30 seconds. If you feel that your ab muscles are working, bring your hips back to release that pressure. Exhale and tuck your hips as you roll the ball towards you, bringing your spine to an upright position. This can also be modified into a normal child's pose by lowering the palms to the floor and the seat to the heels. The straight leg glute kickback strengthens the glutes and hamstrings and relieves pain due to long periods of sitting. It supports the lower spine and the abdomen. To do the straight leg kickback, set up on your hands and knees with your hands under your shoulders and your knees under your hips. You also want to flex your feet. Then we want to kick one knee back. We get back to that. There we go. Kick back, driving your heel into the wall behind you. Squeeze the glute as you lift the leg and drive the heel toward the wall behind you. Make sure to keep your arms straight as you kick back and your abs engaged. Don't arch your back just to try to kick your leg higher. Try to get your quad to about parallel. I am so sorry. It's kind of jumpy with these videos. The height of the kickback doesn't matter as long as you feel like your hips are extended and your glutes are engaged. You don't want to feel this move in your lower back. Hold this for a second or two at the top and really contract your glutes before lowering back down. Definitely don't rush this movement. The slower you go and the longer you hold, the harder the move will be. Complete all reps on one side before switching to the other side. This is the kneeling spinal twist. This loosens and moistens the synovial joints in the vertebrae, stretches the shoulder blades, and is good if you find yourself hunching over a lot, especially while sitting. To do this, you want to start on all fours in a tabletop position with your shoulders directly over your hands and your hips over your knees. Engage your abdominal muscles to protect your lower back. Press your left hand into the carpet or mat and extend your right hand, palm open towards the ceiling. Follow your hand with your gaze and repeat on the other side. This is the neck stretch. You want to make sure to do this that your body is in proper alignment. Your head should be stacked above your ribs and your ribs above your pelvis. Clasp one or both hands and bring your palms to the back of your head. Gently press your head down towards your thighs, tucking your chin into your chest. Hold this for at least 30 seconds or 5 to 8 deep diaphragmatic breaths in and out. The seated shoulder stretch. To do this, you want to start standing or sitting tall, and then you place your left hand on the middle of your back, palm and elbow pointing out. Reach across the back of your body with your right hand and grab onto your left bicep or elbow. Gently pull your shoulder blades together, holding each elbow in your palm. Hold this stretch for at least 30 seconds and then switch sides. Here we have the seated chest stretch. To do this, start by standing or sitting. Place the hands behind the head, elbows wide. Pull the elbows back further behind the ears and hold the stretch. Your hands can be clasped, but keep the head upright. This is the hand-to-wall shoulder and chest stretch. To do this, you want to stand upright in front of a doorway or wall. Place one hand and forearm into the side of the doorway at shoulder level. Lean forward until you feel a stretch along your chest and in front of your shoulders. Hold this for 20 to 30 seconds and then switch sides. This is the lying shoulder stretch. To do this, you want to lie on your back and gently roll onto one side. Extend the bottom around straight, resting your head to cushion your neck. Bend your top knee and press your foot into the floor for support, toes pointing away from you. Keep your other leg straight. You should be slightly supporting yourself on this hip. Reach your other arm forward in line with the shoulder and press your fingertips into the floor to create a slight twist in your spine. And let's demonstrate that one more time. The next is the wrist extensor. Get into this position on your hands and knees with the fingers pointing toward the body. Slowly lean forward, keeping your elbows straight. Hold this position for 20 seconds, relax, and then repeat the stretch itself. This is the overhead tricep and shoulder stretch. Lift your shoulders up toward your ears and then draw them down and backward. Extend your right arm to the ceiling, then bend at the elbow to bring the right palm toward the center of your back, resting your middle finger along your spine. Use your left hand to gently push your elbow in toward the center and down. Hold the stretch for 30 seconds for 3 to 4 repetitions on each side. This is our last stretch. This is the neck and shoulder stretch. To do this, bring your feet a little farther than hip width distance apart. Bring your right hand behind your lower back by bending the elbow. Keep your palm facing outward. Gently grab your right wrist with your left hand and pull slightly while tilting your head to the left. This will lengthen and stretch the whole right side of the body and neck. To deepen the stretch, lean slightly to the left, keeping the hips square and the core engaged, and then repeat on the other side. Well, in conclusion to today's presentation, keeping ourselves safe for the long run isn't just about the number of patients we scan in a day or how many hours we put in a week. Well, that certainly can be a detriment. Oftentimes it's our mindset and the effort we put into maintaining our health before and after the workday that can also promote a long and healthy career. Before we take your questions, I do want to give a huge thank you to our team members that helped put this all together. Becca Friday for all of her hard work collecting the awesome stretches and exercises for today's presentation. Samantha and Ashlyn from our Kansas City region for volunteering to be the models for our do's and don'ts section. And finally, Stephanie Lee, who works her tail off in the background to get your CMEs rolling and to promote all of these presentations. And finally, thank you all for joining us again. I hope that you found this information to be quite helpful. Our next webinar will be on June 23rd for transcranial Doppler. So please join us then. We would love to have you. And at this time, we'll open it up for any questions.
Actually, we don't have any questions, but we do have a comment.
Okay.
Thank you. Really enjoyed the webinar. I'm especially interested in trying out some of the stretches demonstrated, especially for the neck and spine. So
very good. I hope that you were able to try those out, and hopefully they work for you.
And that's all we've got.
Oh, well, thank you again, everyone, for joining us. Like I said, you should get a follow-up email regarding your CMEs. And again, please join us on June 23rd. We're happy to have you.